The following podcast was recorded at the ANZICS Safety and Quality Conference 2014 Rapid Response Teams. Daryl Jones talks about resourcing of rapid response services throughout Australia.
Thanks, Liz. As Liz alluded to, we've heard three fantastic talks on how individual hospitals do things differently. I'm going to give a more global perspective on how things are resourced in Australia and who attends Met calls. Again, this was sponsored by the Commission, so it's only Australia. But I'm also then, just because it doesn't fit anywhere else in the program, talk about, as Alex briefly alluded to, the triggers that we actually use to activate the systems. As you've heard, there's significant practice variation in the way we do things between hospitals. And as Rob alluded to, that's appropriate because we have different resources. But what I'm hopefully going to convince you of before the end of this talk is that sometimes this degree of variability is not safe. And this is a safety and quality conference. And what I'm going to present to you, I think, hopefully will make you concerned. So I'm going to talk about the ANZICS core survey that we did in conjunction with the first study that I presented, and talk about the team composition and the calling criteria. And then Alex has just alluded to this study, so I'm going to talk about this, and thank you for Alex and Jennifer for letting me present it. And then I'm going to spend a fair bit of time thinking about or discussing what I think the implications are for training of our doctors and nurses, also the research and quality implications of interpreting it, and the patient safety aspects. So when we did the study in 2010, we sent a single page out. The details aren't important because I'll go through it. It was just a single Word document, and we asked each of the hospitals to tell us about their hours of operation, days of the week, who was on their medical emergency team or rapid response team, details of funding, and we also asked them just to send their MET criteria to us, which they all did. And so we got data from 39 hospitals. There were 4 paediatric ones, and the detailed paediatric data will be coming out later this year. All of them operated 24 hours a day, 7 days a week. Most concerningly, 75% of them had no additional funding. So this is in 2010. It may have changed since then, but 3/4 of the hospital had absolutely no additional funding to staff and resource their rapid response team, which I find concerning given the number of calls we're seeing. When you looked at the staff composition, 3/4 of the teams were run or had an ICU registrar. About 1 in 8 had an ICU resident, and as Alex alluded to, very few of the teams actually had an ICU consultant. And there was an internal medical registrar. This was published for an American journal, so these tables are from. Basically, a gen med registrar was present in a significant proportion as well. So this sort of co-management, as Rob's alluded to and Alex alluded to. ICU nurses were present in 3/4, nurse consultants were present in a further 10%, and there were various other people, CCU nurses and ED nurses. These are obviously typically the smaller peripheral, maybe rural regional hospitals. So there's quite significant variability in the staff who are composing the team, and in particular, there are very few consultants who are on the team, and I'm sure many of you will empathise with this. So although 38 out of 39 were what we would call a physician-led medical emergency team, so they actually had a registrar at least on, there were very few had an ICU consultant. And Teresa Jakes also did a survey of our trainees and reported this exact fact in 2008. And the registrars felt somewhat unsupported in this regard, in this outreach role. Of significant concern, and it might be that there's a backup mechanism in which for when this situation arises, in 7 of the 39 sites, the most senior person probably couldn't intubate. They were either an ICU resident or a general medical registrar. So the next thing we looked at was the calling criteria for the hospitals, and we found that, as Alex alluded to, there was profound variation in the calling criteria, both in the way they were laid out in the poster, but also, as we'll see in a second, the thresholds for activation. Virtually all of the hospitals, in fact, I think all of the hospitals had single parameter triggers, and I won't spend a lot of time going through them. Most of them were structured. Most of them had evidence of threatened airway. A significant proportion had a dual cardiac arrest medical emergency team where cardiac arrests and respiratory arrests were included in the activation criteria. There were quite profound variations in the stipulations for FiO2 with the hypoxic criteria, and there are also marked variations in the number of the additional criteria and their wording. But of greatest concern to me was the variability in the activation criteria and, more importantly, the extremes thereof. Now, keeping in mind the MET is a preemptive intervention that sees patients relatively early in the course of deterioration to prevent cardiac arrest, and at this stage we haven't had a lot of evidence to support their effectiveness, and I think that these slides will maybe give a little bit of indication as to why that might be the case. So in Australia, the most common upper limit of heart rate at the stage where this study was done was 140. Now that might be fine if it's AF with no compromise, but I would contend if that's sinus tachycardia, you're in trouble. Similarly, when you looked at respiratory rate, some sites allowed patients to only breathe 5 times a minute before you called for help. But of greater concern was that, for me, was the upper limit of respiratory rate. And 36 was the second commonest trigger. And again, if someone's in respiratory arrest, I would hardly call this early recognition in response to deterioration. So maybe our friends across the Tasman perform a bit better, and thank you again to Alex and Jennifer for allowing me to present these slides. They did theirs in October 2011 across the 20 health boards, as Alex has alluded to. There were significant variations in the number of scored parameters, and they similarly found quite significant variations. So some patients were allowed to only breathe 4 times a minute before you called for help. I'm staggered you would wait that long to see if someone breathed their next breath, but that's okay. And similarly, they had a significant proportion, although less than Australia, which is good, where the trigger was above 35. Heart rate lowest was mostly 40, and a majority were above 130, but there was still a significant number above 140 up here. Of greatest concern to me, and I hope it's maybe a misprint, is that they wouldn't call a MET call until the systolic blood pressure got less than 70. So I was speaking to Gerard, who's from New Zealand, one of our registrars, and I said, clearly it's because New Zealanders are tougher than Australians, clearly. But he assured me that there's less brain to perfuse for New Zealanders. So I'm not too sure of it. Anyway, so I think this has got quite profound implications for quality and safety. There's variation in staff composition, calling criteria, and the allocation of resources to review these patients, who I told you in the last talk have a 1 in 4 mortality. And this results in what quality people called undesirable practice variation. So patients are going to be reviewed at different phases of the illness, there's going to be variable responders, and clearly this is not the same thing in every hospital. But what I'm most concerned about is some of these very abnormal MET criteria are actually endorsing the fact that this is okay to have this blood pressure, keeping in mind, or respiratory rate, keeping in mind that these are meant to be tools to assist decision support for relatively junior and non-critically care trained staff on the ward, and I just don't think some of them are safe. So put it another way from the patient perspective, if you have a respiratory rate, in some hospitals you'll get a MET call and an ICU consultant will come and see you, whereas if you're in another hospital, you won't even get a MET call, and if you did, a HMO would come and see you. So just think about that for a while. And clearly this is like comparing apples and oranges. It's just not reasonable to compare these different systems. So I would question whether the rapid response team can be effective if you wait that long. And if you've got the same condition in different hospitals, you're going to have different outcomes. And it makes it difficult comparing sites, and it makes it extremely difficult if you're going to plan research or quality improvement initiatives in these hospitals. And Julian Bion, who's an eminent intensivist from the United Kingdom, actually said this in an article. He said it's very unwise to assume that the context in which the rapid response team is applied is similar in all hospitals. He was obviously ahead of his time. But I also think this has got implications for training. Now, this is an ANZICS conference, so I'm focusing on our doctors, but nurses similarly. If only a quarter are funded and we're seeing 20,000 calls at least a year, keeping in mind this might be as high as 40 or 50,000, then if the registrars are leaving the ICU all the time, they've got less exposure to critical illness. So they're not spending time learning about intensive care, they're spending as much time learning about patients who are sick on the ward. It's also got safety implications for ICU patients, and I note that there's a poster talking about adverse events when the team's outside the unit. But also it's got, if you think of the way we train our registrars inside the unit, we have a mentor system whereby a senior consultant teaches and trains an upcoming and developing registrar. This does not happen in the Met, and I would contend that these things are less monitored, less controlled, and more challenging than a patient who's continuously monitored in the ICU where you've got all the resources to call upon. And so, importantly, Met assessment may not be as thorough as it could. For each individual Met call, if our registrars are rushed and they're not spending as much time as they should, each patient might not get the optimal dose that they should be getting. And Ken talked about the dose for a whole hospital. But each patient might not be getting as much care as they should. And these are slides I love to put up. This is the Austin, the ICU, balloon pump, ECMO, consultant at the bedside, versus the Met. And it's just not a fair fight. We've got half a registrar and a nurse now, because one of our registrars has to look after a 5-bed pod. And this is what they take out. So we've got all this versus this. And it's not comparable. So I think for people, and I'm not advocating every ICU has to run the Met, far from it. But in cases where we do, I think, my personal opinion, and this may not be ANZICS' opinion, that we actually need to develop a business case for advocating for our units, for where people want to run and staff the Met, that it needs to be done centrally from ANZICS and KICM. I think that there's significant evidence will probably reduce overtime from parent units out of hours. The registrars are much less likely to come in the environment of the Met. There's a lot of evidence, particularly from the states, that Met-equipped hospitals have much better nursing retention and much lower absentee rates. And most importantly, as Alison's alluded to and Ken alluded to, I think one of the major roles, undesirable and unliked as it is that we actually probably reduce inappropriate ICU admissions. And as Ken alluded to, a third of Met calls have end-of-life care issues. And even when I was a registrar, which is not that long ago, I used to get phone calls about patients who are pending nursing home from the registrar saying, I've got an 85-year-old who's got mild dementia and 5 comorbidities, and the family want everything done. And you'd literally have to go there and unpick that. After the decision has been made by the family, sometimes the patient and the parent unit, that the patient was coming. And this is in jest, but this is how it ends after the Met's been involved. We often go there and start preemptively doing end-of-life care, and I think we prevent a lot of inappropriate, for want of a better word, ICU admissions where the patient is not going to benefit from intensive, invasive and burdensome therapies. So in conclusion, in these 35 sites that reported having a Met 24 hours a day, only a quarter had funding, and there is quite marked variation in the team composition and the calling criteria. And as I said, this is a safety and quality conference. So I think that I have grave concerns about some of the thresholds for the calling criteria, and maybe one of the roles of ANZICS could be to advise, or the Commission could be to advise, not mandate, but to advise about safe thresholds for calling criteria. There's certainly a lot of practice variation, and it makes comparing sites very difficult, and I think increasingly for hospitals that want to do it, I think there's a role for ANZICS, KICM and the ACCCN for us to increasingly get recognition and resourcing for the work that we provide. I think that's it.
For more podcasts from ANZICS, go to anzics.com.au.